everyone. My name is FT Adepeko. I'm the Sexual and Reproductive Health National Project Coordinator for Canadian HIV/AIDS for Black, African, and Caribbean. That's CHABAC network. And the Sexual and Reproductive Health Project is just to increase awareness of sexual and reproductive health among Black Canadians across 4 provinces, the provinces of Ontario, Alberta, British Columbia, and Manitoba. And with me here today, I have a very important and special guest. But I'm not going to introduce her. She's going to introduce herself. So over to you.
Hi, my name is Marvelous Muchenje, and I don't know how to introduce myself because I wear so many different hats. But at the moment, I'm just wearing a hat of a community member, an African woman living with HIV. But I also do a number of activities in the HIV field. I'm a consultant, but I also work for a pharmaceutical company, which I'm not going to name at the moment. But I'm not here wearing my pharmaceutical hat.
Okay, thank you so much for being with us here today. Marvelous. I'm really excited. Okay, so let's get to it. So, as an advocate and educator in the ACB community, how have you evolved over the years in your work in the HIV and the sexual and reproductive health field? Have you noticed any trends or changes over the years, or have things just remained the same?
I think I'll also focus on HIV, but I'll also focus on just the general population of
Mm-hmm.
African and Black people. I have worked in the field in various roles. I started off as an administrator, and then I became an advocate for sexual and reproductive rights. But I also was a social worker, a case manager. So once you wear those hats, it's so difficult to take them off. You at one point or the other, you always find being involved in either in research projects or being involved in various interventions that are implemented. So I have seen. I will first of all talk about the HIV side. So when we talk about HIV and sexual reproductive health, we've really seen a great change. There's the availability and use of antiretroviral drugs has changed over time. And by antiretroviral drugs, I'm talking about the medication that people living with HIV take so that they live longer and also to prevent the replication of HIV in their body. So that has changed over the years. The changes include taking lesser medication and
Mm-hmm.
in some extent lesser toxic medication, but that has also gave hope on the sexual reproductive front, because there was a time, like for me as a person living with HIV, I didn't have when I was diagnosed with HIV in 1995, I didn't have hope to think that I was going to have a child or I was even going to have a relationship. I thought that was the end of the road. But with taking treatment, a lot of women have given birth to HIV negative children, and they've been in relationships with people that are also either negative.
Mm-hmm.
And that has given hope to a lot of people. And that meant also we had to change the way that we deliver our programs, whether they're HIV prevention, because we are seeing people who are in what we call serodiscordant relationships, where one
Mm-hmm.
is HIV positive and the other one is HIV negative, which means you have to have conversations on how do you continue protecting your other significant others. But I also have seen that even the choices of reproductive health have changed. A lot of people are also thinking about IVF. As an
Mm.
African, those are things that we never talked about. We've
Yeah.
seen people adopting children. As a community, that is something that was looked down upon, to say why the emphasis was for you as a woman to be able to give birth. The moment you get married, everyone is asking, are you pregnant yet? Do you have a child? Is it a boy? Is it a girl? Those things have changed. But also,
Yeah.
the immigrants, I've seen changes too. And the way we talk about sexual reproductive health has to change, because you are going to environment where people call a penis, a vagina. So which means that also has brought people to be able to build their advocacy skills, to request for services, but to be able to talk the language that the other people also understand. So the other trends that I can highlight also without taking too much time, there is also I've seen a lot of the sexual and reproductive rights not being standing alone in a silo, is being integrated within other health promotion, where we are
Mm.
promoting about HIV prevention, where we are promoting about diabetes, where we are promoting about high blood pressure. We are also talking about cervical cancer. We are also talking about HPV. So the integration and coordination of services is changed, but that doesn't mean there's no challenges. There's still challenges. We are seeing that there's persistent health inequities that prevent many people from accessing the health services, either the distance, or maybe you're busy working in the hours of accessing the care do not fit in your calendar. But also other responsibilities. You have to take care of your kids. There's no child care, and those are also hindering people accessing services. But also, we've seen a high rise, although we don't have much research done with ACB population, but there've been
Mm-hmm.
a high rise of sexually transmitted infections like syphilis and gonorrhea. With other populations, we've seen that they are doing, like indigenous populations are also starting to do develop programs that address those. But in our community as ACB, we are not really talking about it. It's a few people that are even talking about it. Even the crisis of opioid, we don't talk about harm reduction in our community that much, but that hinders also how we access services, how we
Mm.
talk about reproductive health.
Yeah. Thank you so much. Marvelous. Um, you actually touched on my next question.
Mhm,
So I guess I'm going to skip it because I was going to ask you what your
mhm.
experience has been, as a community member accessing sexual and reproductive health services. But since you
But
touched on that,
I think I can jump in and
okay,
just talk about something that I didn't talk about, the issue
okay.
of and I know you're going to be asking it later on, but the issue of stigma. The stigma is continuing rising. Because we're expecting by now to be HIV stigma to be at a lesser rate than
Mm-hmm.
before because of the access to treatment, but it continues to be there. And but also the other thing that we are seeing as a gap is the involvement of male gender
Mm.
in antenatal care, and how they don't get involved. There's no programs that are targeted at families. They're few. There is, and if you, and like when you look at our counterparts, like most other communities, they have programs actually that bring the father from the beginning of the
Mm.
pregnancy. They go for the antenatal classes. They are participating. They are singing to the baby while the baby is in the stomach. In our
True.
community, you'll be seen as if, are you crazy? What are you doing? So I think that is still a gap of especially for heterosexual men, how they get involved in the life of their family, even in those conversations. But also, we don't acknowledge the diversity of our community as ACB population. We are diverse. We come from different backgrounds, so which means our teachings on health are different. So one size does not fit all. So we need to also see where how can we engage in a meaningful way that will actually address and acknowledge what we go through as a community.
Okay. Thank you very much. So, are there any other important strategies that you have found to be helpful in ensuring safe and fulfilling sexual and reproductive health choices among the ACP community?
Yeah, I know CHABAC, together with organizations like Women's Health and Women's Hands and others, are working on innovative ways of communicating and talking about HIV prevention. People are going, actually, peers are going in the community and delivering services rather than waiting for people to access services within a community health center or within an AIDS service organization. Workers are actually going where people are, and by where people are, I mean even within churches. They are going
Mhm.
even within buildings, like community buildings, and just set up a session where they're relaxed, people don't feel judged, and they talk about anything about reproductive. And then I've talked already about not developing programs that one size fit all. So depending with which population you're serving, the presentations also are different. People are coming up with innovative. If it's youth, maybe engaging in more on people are now using TikTok, people are using Facebook, so using social media also has really increased awareness. But develop also new messages, new messengers, and new methods of increasing awareness. And I was talking to someone not long ago, even when I was in Edmonton, and they were asking a question that why is it that we don't see billboards like what we do when we're in Africa or so those things we need to, because then when you have a population coming as new immigrants and they are not seeing those billboards, they think HIV doesn't exist in this country.
Mm.
So we have to mix both best practices in the south, like in Africa and other countries, and how do we bring those models from there and implement them also in the north. And the concept of risk, because when people talk about sexual behaviors and also transmission, we always talk about risk. So when someone doesn't see themselves as they belong to a risky population, they say it's for them, it's not for me. So
Mm.
moving away from that, using the word risk, and moving more into targeting everyone, to say everyone has to take care of their health. They don't have to give the responsibility to someone else to protect themselves. And I've seen in our community also as ACB population, we are narrative. We are very narrative. We're storytellers. So trying to do storytelling just in a group, in an informal world, just bring any topic about sex to women in a less formal environment. You see how excited they get. But if you make it a PowerPoint, people don't get it, they disengage. So let the women lead the discussion, let the women take control and mention what works for them. And also the other thing that I've seen is from the we have to target from the young, when they are young, like in schools, trying to find out how do we get into schools, how do we get into youth programs and start talking about those things. Because if you're trying to implement this, some things that I'm told now, if I try to do them now when I'm 51, I can't even do them. So if I had those conversations when I was 16 or 18, it would make me make an informed decision.
Yeah. Okay. Okay. So we did mention or touch briefly on
Mhm,
stigma.
mhm.
So in your own experience, how does this stigma towards sexual and reproductive health, how does it show up in the ACB community? And how can we reduce this stigma apart from the ways you have mentioned?
So for me, I think before I even talk about how do we do that, when I look at stigma, stigma is associated with poor physical and mental health outcomes. And stigma and discrimination towards persons living with certain health conditions, also including like mental illness, substance use disorders, HIV, cannot be understood or treated separately from stigma related to other characteristics like race, gender, and
Mm,
sexual orientation and age and income. So when we think about stigma, there's so many intersecting factors that
mm,
contribute. So if you fail to look at what is contributing to that, you won't be able to adequately address stigma. And stigma related to sexual and reproductive health itself has got deep roots in our society. I don't
mm,
think even you or any other listeners that are there, like if you try and recall, when did you start to know what your private part is called, or the name of it, or even how babies are made? Some of us maybe later on, when we started, even when you started having your menstrual cycle, you didn't even know where the blood is coming from. What
mm-hmm,
happens? You were just given, put this cloth on, or no discussions. You were just told.
mm,
Now that you, I still remember one of the conversations I had was, now that you've started having your periods, don't sleep with a man. But I wasn't told, why shouldn't I sleep with a man? What happens? What about or if that happens, how do I protect myself? And
mm,
for me, I think the stigma of even starting the conversation on sex is a real big taboo for our community. Just talking about sex is very big. And um and also stigma and its close cousin of shame can keep people away from requesting contraception, even at a clinic, even if for young people, or even for those that are not positive, to ask for prep, to say, okay, how do I prevent myself from getting HIV? Because you don't want to be deemed as if you're promiscuous. Why are you asking those things? So it's, when we look at stigma, it's mostly associated with things that are seen as sinful. Somehow, having sex is seen as sinful rather than pleasurable. So that's
mm,
where the stigma comes from. And also, it can make sexual assault victims also reluctant to seek medical care or report even this assault, because when you get on the phone or when you go into a service to report what happened to you, it's always, the questions are very stigmatizing, like you ask for it.
mm,
So
mm,
even when you are raped, it seems like you've asked for it. So
mm,
there needs to be a change in how people look at things, and also learning which words are stigmatizing, like risky behavior, and changing the language and make it more positive. And so, how can we address it? I think we need to address it by naming it and recognizing racism, homophobia, transphobia, and other stigmas related to social identities. Because as much as you don't believe in homosexuality, we are forced to be working in environments where we work with diverse populations. How are you going to provide services without being stigmatizing? And then we need also to produce guides for healthcare providers on using neutral language and protect sex, not risky sex, talking about sex workers, not prostitutes. But things constantly change. I've been in this field for some time. Even the acronyms for LGBTQ2 plus have been changing. So you need to be keep on learning what's new. What is the language that I can use? How do I use pronouns on people? So we need to keep on abreast with what's taking place. We need also to understand the common drivers and practices and experiences of multiple stigma, for us to be able to collaborate and work together to address the stigma. Because one organization like CHABAC cannot address all the stigmas. Someone else needs to take another piece, but we can only do that by doing a coordinated effort and providing services.
mm. Thank you so much. So I really like when one of the points you mentioned, like just naming it as it is,
Mhm,
naming stigma as stigma and identifying it so that we can actually address the root cause.
mhm,
So, something that we noticed as one of the barriers to utilization of sexual and reproductive health services
mhm,
is an underrepresentation of the ACB population among healthcare providers.
mhm.
How would you suggest that this challenge is addressed? Oh,
I think when we look at the challenges of employment and employability, this is broader than just when looking at sexual and reproductive health, because you
mhm,
have to look at accreditation. Some people already came with skills from back home as nurses, but it's getting those accreditation for them to be able to practice in Canada.
Mm,
And so it's trying to identify and develop programs that actually build the capacity of people who come in the country to be able to practice. We have doctors. I've seen doctors who are working in other fields that do not even those are lost skills that we are losing. So
mm,
how do we what do we need to do as organization to make sure that we give room and space for those people to practice? So this requires also changing the policies, not only just at the grassroots, but policies, including federal policies and all those other things. But if we have also people that are willing to be volunteering to do facilitation, or who are willing to be peers, and working in sexual and reproductive, we need to create environments that also allow them to do that in spaces.
mm,
And just recognizing that me being African doesn't mean that I understand everyone's culture. So you
mm.
need also to think about, okay, are we talking about people from Southern Africa? Are we talking about people from West Africa? Are we talking about people who are Muslims and who are maybe Muslims from the West? Or so there's so much things that we need to take into the so we need diverse ACB service providers to be in the spaces to bring their skills, but also to get updated on what things change. You need to find a way like mentorship. There need to be mentorship where people mentor others to be able to do the work that they are doing, so that there's a lot of us on the grass or the ground to be doing the grassroots to be doing the activities, but also empowering youth.
So, something that you said, like, it's not just at the individual level, it's
Hmm.
also at the, policy level.
Yeah.
And I think I agree with you on that. So, my
And
final
also
question.
I think just last but for us to effect change, you need data.
Hmm,
So at that policy level, and we know already most of the ACB organizations have done some research, they've done some evidence-based activities that brought them like recommendations that work for our community. So we need to also move that data from the shelves and put it effect it so that it moves into programs or into policy change. So don't just collect money to do research and you sit on the data. But how is that data going to influence how we are going to provide cultural appropriate services that meet the needs of newcomers or diverse newcomers?
thank you very much for that addition. I like that piece on getting the data out there.
Mm-hmm.
We already know that there's a scarcity of data among the
Mm-hmm.
ACB population, but even the little data that we have, we need to get it out there
Mm-hmm.
so that can be done on it. Okay, so my final question for you today, Marvelous, is that how do you envision an inclusive and culturally diverse sexual and reproductive health system for the ACB community? And apart from all the steps you've listed today, what other steps can be taken to move towards that vision?
So for me, I think we already know the gaps. We've done enough research. We've already what is missing is the resources.
Hmm,
We need the resources to implement what the lessons that we've learned or to pilot test. There's so many. I still remember when I was working for Women's Health in Women's Hands, and that was about 6 years ago. We took a model called Willow. It was developed in the US, and it was an evidence-based program. It was done with African American women. When we looked at it, we looked that it fit well also in the Canadian context. What was missing was the immigration part and the cultural part. So we just took, and it came already with suggestions on how to adapt the two. So
hmm,
we looked for funding, and we actually revisited the model and changed areas. So there's no need to reinvent the wheel. Let's look at what has worked and how can we implement it. I have two suggestions of interventions that I think are already have already been researched, and ACB populations has participated. Women's health and organizations maybe like HIV Edmonton and others and CHABAC might have participated in some of them. There is one that was developed by CHIWOS. It is called Women Centered Care Model, and it's online. I can follow up with the linkages to these resources so that when you can share with your community. It's a model that looks at trauma and violence awareness care, looking at women not just as an individual but looking at patient-centered care. It involves paying attention at social determinants of health and family, and because we know as women, most of us, our family also comes first. Looking at the needs of our family, if my family is not addressed first, I don't care. Forget I have HIV. I need my child to have certain things. I need to have my immigration status. So that's the first floor of the model. And then the second floor of the model is divided actually into three rooms, which looks at competent HIV care, which is integrated with women's health, including sexual and reproductive health. And then the other piece is mental health, because mental health is really not looked. There's so much stigma on mental health. People have got loss and grief just by migrating from our countries. We go through a lot, so we need to look at also mental health. And then there's that also the other component of addiction care, because addiction, we only think it's just other populations, but we also have it. We might not have like people using injections, but we can be overusing alcohol. So it looks at all that too. And then it looks at peer support and leadership and capacity building. That needs to be integrated also to include to help improve the sexual and reproductive and HIV too. And there is also another model which was developed by Viv Healthcare, where I work. It was pilot tested in the US with African American women. It's called Risk to Reason. It has different tools that are there already. You can just take and use them according to how you want to use them. But I like that it looks at changing the language from risk to looking at what are the reasons behind. But it also looks at it looks at pleasure, and how pleasure and intimacy are real reasons for self-care and HIV prevention. It's about framing how we look at health and wellness, putting pleasure at the top as a reason and a way to support your health. It also looks at respect and recognition of the whole person, not just looking at my HIV status or not just looking at my mental health, but look at me wholly, because maybe I might say I have a headache, but it's not just a headache. There's something else causing the headache. And then bodily empowerment and autonomy, being able to promote self-love and self-care tools to empower women to be able to talk about. Some women don't even know how their vagina looks like. If you ask, they don't even know when it's healthy, how does it look like? When it's unhealthy, how does it look like? Which one is a healthy discharge and not? And it looks at freedom from fear and shame. That's nurturing that open discussion. But lastly, it also looks at the HIV stigma free communication and treatment, normalizing conversation on HIV prevention, and also just the standard of care. I think for me, those some of the tools, they're not the only ones. There's so many other tools that are there. So creating platforms where people can share what they are doing and how are they actually expanding the sexual and reproductive health to youth, even to the boy child. Because who is going to teach the boy child? We come here in the diaspora, there's no aunties, there's no uncles to talk to our boy child. We are the ones who are going to be the aunties to talk about the penis, about the vagina to our sons, and how to respect women. If we don't do it, no one else can.
If we don't do it, no one else can.
Yes.
Yeah, I'm taking that away with me from this conversation. So it all begins with us. We should not leave the job to an outsider. We should not leave the job to a third party. we should all be invested in this as a
Mm-hmm.
community, and we should take the forefront. We should be at the
Mm-hmm.
forefront of advocating the right sexual and reproductive health practices. Okay, with that, we've come to the end of this informative session. Thank you so much, Marvelous, for your time. It's been amazing learning from you, and I'm sure that those listening as well would say the same. Thank you so much. So, until you hear from us again, my name is FT Adekpeko, and I'm with the Sexual and Reproductive Health Project at CHABAC. Thank you so much, Marvelous.
Thank you.
And with that, we've come to the end of the podcast.